The next technique is volume ventilation. One of the questions is, where is it measured? Is it measured at the ventilator? Is it measured at the Y where you're connected to the endotracheal tube? Those that are measured at the Y are more accurate for the baby, and most measure now exhaled tidal volume, not inhaled, as to adjust from, because most babies don't have a cuff tube and therefore have some leak, and so the inspiratory volume may not be what's actually delivered to the patient, and therefore the expiratory volume is more accurate as to what has been delivered to the patient. What about volume ventilation? Well, it clearly stabilizes lung volume because you set the volume at 5, 6, 7 cc's per kilo, and you deliver that volume relatively constantly, and so the lung remains adequately inflated. And there's an automatic weaning process. So the ventilator will use a pressure needed to give that volume. As compliance improves, that pressure will be decreased because not as much pressure is needed. So you get away from the pressure being the limit, rather you have the volume being the limit. This would give you better ventilation perfusion matching because you get away from atelectatic areas and over distended areas. It also gives you a better stabilization of cerebral blood flow because your CO2 stays more normal and isn't changing widely, and because you're not over distending the lung and causing impedance of venous return, and because you don't over distend the lung, you reduce the chances of air leak. The disadvantages, of course, are pretty much what some of the advantages are. One, of course, is that if the endotracheal tube gets put into the right main stem bronchus, you've set the volume at 5 per kilo. Well, all of that volume will now be delivered to only a portion of one of the lungs, and so you can injure the lung because of that. And if you've chosen the wrong end expiratory pressure, the lung may be over distended, and you will injure it because you now over distend it even more by the volume that you are delivering it. And sometimes you have a poor volume control because sometimes the baby breathes very vigorously, and so the volume needed to go with the baby's breath is not very much, and then all of a sudden the baby stops breathing, and so the volume delivered is inadequate for the baby. And for the very tiny babies, sometimes the triggering mechanism is not as good, although the newer ventilators appear to be much more sensitive and work better for even the very small baby. Pressure support is a technique that was used in the adult to wean them from the ventilator, and is a technique that's now being used in the neonate, typically associated with the volume guarantee mode. And really what you're doing is that you are partially supporting each breath that the baby takes, but you're making them assist the breath, and you're improving their muscle tone and their respiratory drive. And so you really are assisting them in getting them in shape to come off of the ventilatory support. So pressure support is a mechanism that's being used a lot more recently, particularly as you're attempting to wean the baby from the ventilator. The thing you must remember is that when you're in the pressure support mode, every breath is being supported. When you set a rate, that is the backup rate if the baby stops breathing. That's not the rate of pressure support. So that sometimes if the patient's overventilated, turning that rate down is of no benefit. What you have to do is you have to turn the pressure support down. And then the last two are ones that are not specifically used or the MMV is not specifically used in neonates, which is the mandatory minute volume. And the reason in the neonate is because Neonates may breathe 60 times a minute, and then they may have short periodic breathing, and their rate may go down to 30 times a minute. And you have to keep recalculating to get that number. So that's not a mode that appears to work very well in the very small baby, although it will work in the older child or infant or adult. Volume guarantee mode is just trying to assure that you get an adequate volume, and typically we would use 5 to 7 cc's per kilo for babies. And if they're doing really well and become very compliant as they're weaning, obviously that volume can be decreased from that standpoint. Volume ventilation today is a much better technique than it was 20 years ago because of the devices that we have and how well they measure volume. Well, getting back to these issues, one thing you must remember is that people believe that, well, 5 cc per kilo, it's lung protective, I won't hurt the lung. It really doesn't ensure prevention of lung overinflation and lung injury. And a 10 cc per kilo tidal volume doesn't ensure overexpansion or lung injury. It depends on where the lung is at any given point in time, and so that becomes critical. And I'll just show you some x-rays here. And this x-ray obviously is a baby whose lung is overinflated, probably because the baby's on an end expiratory pressure that's too high, or maybe the baby has some increased airway resistance with that. Well, if you deliver 5 per kilo to this baby, you're already starting with an overinflated lung, and you will further overdistend it, and you will injure the lung with what you believe to be a lung protective strategy. On the other hand, you look at this baby whose lung is not very inflated at all, and if you use a 5 per kilo tidal volume, you're not going to get this lung inflated. This lung, you will require very high oxygen concentrations, and the lung will be injured from that. And so if you go to a 10 per kilo tidal volume, you can recruit the lung. And once you recruit it, then you won't need the 10 per kilo. So the key is you may need 10 per kilo for a short period of time to get the lung recruited. Once recruited, using the end expiratory pressure, you can drop back to a 5 to 7 cc per kilo tidal volume and be lung protective. And this slide shows a baby who has almost completely atelectatic left lung. And so a 5 per kilo tidal volume to this baby is really all being delivered to the right lung, which is the right lung really seeing 10 per kilo, which could be overdistending and very injurious. So again, what you have to deal with is the atelectatic left lung, and fixing that is what will become then lung protective. So if you're weaning from the ventilator, and that allows the lung to collapse, and you go to the lower portion of the pressure volume curve, you're going to injure the lung, not protect it. So being aggressive at trying to use the smallest tidal volume possible may prove to be lung injurious, not lung protective. And the key here is you must tailor your ventilator strategies to match the cardiopulmonary pathophysiology that you're dealing with. If you do that, you will have good results. So conventional ventilation now has moved from the time cycle pressure limited mode more frequently to the volume mode because we measure it properly and that. But remember, smaller is not necessarily better, and you must use an adequate volume and an adequate end expiratory pressure to keep the lung in the mid portion of the pressure volume curve and avoid over and under inflation. And if you do that, you will clearly be using a lung protective strategy. Thank you.